strategy depends on many, many.
Some countries have more experience with outbreaks of infectious disease, and some parts of Africa actually have built up these systems robustly, even some of the most resource-limited settings, because they are used to having outbreaks of infectious diseases, where other countries, some of our countries, perhaps less used to having the outbreaks of infectious disease. From what we know of the experiences around the globe, that public health interventions are by far very important and effective to flatten the curve. And I don't have a picture of the flattened curve, but I hear that the main points from this slide are, obviously here is introduction of the virus, here is early detection and local transmission, and this amplification phase can take different curve designs, in the meaning that it can be very accelerated with a doubling time between 2 and 3 days, which some countries have seen, or a more delayed doubling time between 4 days, 5 days, up to 7 days, which countries have also reported when they implement public health interventions.
You can see the epidemic curve with the surge in the number of cases, which is very similar to what has been shown by Professor Bindu before for Wuhan. So you can see that this is spreading. It's spreading all over the country. During at least 4 or 5 weeks before the first case was diagnosed, we had some cases of upper respiratory tract infection or atypical pneumonia that were misdiagnosed as flu, and that were probably due to the start of the spread of the coronavirus infection.
We have a substantial number of trials that are going on in Italy to trying to assess the appropriate therapy for these patients. We have information regarding the antivirus therapy. Some they work, some they don't. We don't have information regarding steroids, and this, I think, is a major question. There are scientific societies that are suggesting actually the use of steroids. We have previous data showing that use of steroids in virus pneumonia-induced ARDS are actually dangerous. As a matter of fact, we don't know. As a matter of fact, I can tell you that in the clinical practice, more than 30% of the patients are receiving steroids.
We know that the ability of COVID-19 to spread has an R0 of 2.5, making that the problem is really how we can stop the disease, and the containment has been suggested not only by the evidence that there are clusters of people who are contaminated by being approximative to each other, so this is why we recommend people to stay at home, but also we know that the psychological impact of quarantine makes that family members that are far from the patients are also experiencing many different symptoms: stress, confusion, anger, and many issues with communication gaps. So we understand that containment is mandatory, but it limits family visits in the ICU and our ability to help them to provide empathy, optimal communication and decision making. And this is also a problem for the patients. This paper published in Critical Care shows that delirium is increased in critically ill patients who are subjected to isolation. The second point stands on the acute respiratory failure itself, and we know that family members of our RDS survivors or patients with RDS who died in the ICU not only have more post-ICU burden, the prevalence is higher, but also it's sustained over time, making that these family members are burdened by the ICU long time after patient discharge. Very few papers that I'm going to report, just this one to show that family members are as sick as patients following ICU discharge, showing very clearly that the burden is on both subjects. We are encouraging critical care teams to open the ICUs, of course with limits and of course with effective PPE for family members, that this is what we do, and we are making that at least one person can enter in the ICU every day to see the patient. Two is that we are providing family members with a standardized written information. Three, we set up routine telephone calls with the relatives.
You need to go after the virus. You need to stop the chains of transmission. You need to engage with communities very deeply. Community acceptance is hugely important. You need to be coordinated. You need to be coherent. You need to look at the other sectoral impacts, schools. And I've learned after so many Ebola outbreaks in my career are be fast, have no regrets. You must be the first mover. The virus will always get you if you don't move quickly. If you need to be right before you move, you will never win. Perfection is the enemy of the good when it comes to emergency management. Speed trumps perfection. And the problem in society we have at the moment is everyone is afraid of making a mistake. Everyone is afraid of the consequence of error. But the greatest error is not to move. The greatest error is to be paralyzed by the fear of failure.
Do and learn. These activities are intertwined. We must learn while doing. And this trade-off is an old one that unfortunately requires an integrated effort.